First and foremost, I'm Dr. Aditya Kidiyoor, and I'll be discussing forensic medicine and toxicology with you guys. And hopefully, this will help you because this is part of our prepathon for 2024, and this will help you with your INI-CET exams. So, each faculty has their own approach as to how they would like for you to handle this subject, and I will talk you through mine as well. So, let's get into it. So, first and foremost, I'm very aware of the fact that many of you will be using only your last few days for forensic medicine. So I want this one session to be as impactful as possible. So I'll be trying to cover as many things as relevant, and also at the end of it, I'll try and make sure that you have some good take-home messages from each topic that I cover. So first and foremost, I've divided the topics into must revise, good to revise, and nice to revise. Now, how this works is these are all high yield topics. Do not get this confused. These are all high yield topics. But there are certain questions which have been asked so often that you must revise them. There is no other option because the chances of them coming again in your exams are very, very high. Okay. So the first of that would be drowning. Okay. Which includes the types, pathophysiology, and postmortem features. Don't worry, as and when we're discussing previous year questions, I will be discussing all of these things as well. Okay. But this is just a list. So if you want, just make a note of this. Then we have hanging with the different types of asphyxia and also the postmortem features. Metallic poisoning, specifically with lead and arsenic poisoning, a lot of questions have come. Then we also have snake bites and scorpion stings. Now, while a lot of people think that this is very confusing, it is very simple. I have given you a nice table as well. You will be able to go through it very quickly. Then we have opium, morphine, and pinpoint pupils. Now, you might think, how is pinpoint pupil a topic? Don't worry, we'll discuss that when the time comes. But for now, know that it comes under the same heading. Then we have the POXO Act. Okay, this is prevention of sexual offenses against children. This act was enacted in 2012, and it seems to be a very confusing topic. It has been asked both in your INI-CET and also in your NEET. So this is extremely high yield because it's a very confusing topic, and people are usually very scared to deal with the survivors of childhood sexual assault. Don't worry, give a very simple way of going about it. Next, we have fingerprints regarding the formation, the types, mutilation of fingerprints, and medical legal importance of fingerprints. Then we have mechanical injuries, specifically the classifications and features. Now, this is must revise. There is no option. You have to go through this. Okay. Next, we have good to revise. Now, there have been questions from this, not too often, but it is very good to know this because you never know. Because these are also questions which have been asked before. So these are also high yield topics only, such as semen analysis, blood stain analysis, Lugol's iodine, bone identification, age estimation. Don't worry, I'll give you some mnemonics for that. Then there's types of evidences and court procedures. Then we have burns, scalds, specifically the depth and percentage of burns, because it's both how deep the burns are and the extent of the body surface covered. Then how do you distinguish between antemortem burns and postmortem burns? Also very important to know. Then we have sexual paraphilias, also forensic psychiatry, few terms, and the test for insanity. This has been asked, I think, about 2 or 3 times in the last 3 years, so very high yield. Then we have postmortem changes in general with time since death. So that's TSD, estimation of time since death. Then we have torture. Then we have blast injuries. Okay, we'll be going through all of this. Don't worry. Now, sorry, excuse me. Then previously asked, this helps to revise. It hasn't been asked too many times, but it is very good for you to know this, which is electrocution and also filigree burns. We have section 320 of the IPC, which is the grievous injury or grievous hurt. Then we have multiple toxidromes along with cardiac poisons and datura, oxalic acid, phosphorus, and what are the samples to be collected in a case of forensic medicine and toxicology. So now that we've gone through this, let me just tell you the basic structure of how I'm going to go over this class, right? So this session is going to go in such a way where there's going to be a previously asked question, right? A previous year's question. I will tell you what the answer is. We'll discuss it together and I will discuss the concept with you. So such that you do not get confused by it if it's twisted and put in a different way in the upcoming exams. At the very end, I'll tell you potential topics, because usually what tends to happen is if there is one main focus, let's say, for example, they want to ask about POXO, right? The POXO 2012 Act that I just spoke about. They might not ask the very same question that has been asked in the previous year. They might take a little bit of a different stance and just ask one question of a little bit of a just one step away from it, like a criteria, what do you say, a criteria magnum, right? So there might be major criteria and minor criteria. They might just play around with that to try and confuse you. That's why it's important for you to know the concept. Just knowing the answers won't help. Okay, so let's get to it. Now, we're starting from July 2021. The first question that they had asked was regarding forensic medicine was a white cloth that was bought by the police was subjected to Barbario's testing. Which of the following does this test detect? Now they've given four options, right? Fructose, choline, spermine, and acid phosphatase. Now, what is the main topic that they're asking about over here? They're asking about semen analysis. Okay. Now, of all of these, which do you think is most likely to be the right answer? The best approach to take here is always that of subtraction or exclusion. Now, acid phosphatase is very unlikely to be the case because there is a direct name for that, right? It is acid phosphatase test. So that is immediately ruled out. Choline, no, that is Florence test. So I will rule that out also. Fructose, no, that's not really of any use to us when we're doing a semen analysis anyways. So your best answer is going to be spermine, and that is the correct answer. Now let's see what all the tests that we usually ask for under seminal examination are. So very good, Sanjay Das. Thank you for answering. But let's just go through the explanation of all these different tests, right? When we talk about Florence test, it checks for choline, right? But this is non-specific. So this can be found in vegetable matter and sometimes even other bodily fluids as well. So it's not specific for seminal stains, but yes, it can detect in other stains as well. Okay. Then we have Barbarios, right? This is what the question was about. This checks for spermine. Now, you need to know the concept behind it as well, which is it gives yellow crystals of spermine picrate. Keep this in mind, okay? Very important. Gives yellow crystals of spermine picrate. Now, why is this important? Because the just in 2022, I think it was, they asked the exact same question. Don't worry, we'll be going through that. But they asked the exact same question, but they just twisted it a little bit, okay? Wherein they said it was subjected to some test, and the stains, the seminal stains turned yellow. So what was the name of that test? Very simple. Instead of going forward, they went backward, right? And this can happen with any of the tests given on this table. So just quickly make a note of it, right? We have acid phosphatase test, which is named after itself only, right? This is found in seminal fluid. Now, what could be the question they ask in this? Here, it is inferred that if there is more than 100 Bodansky units, then this implies that there was an ejaculation less than 12 hours ago, right? The usual value is usually between 240 to 360 units, right? This correctly, 360 units, right? Now, do not get this confused. 240 to 360 is what they usually expect to find. But if it is above 100, then yes, definitely ejaculation would have taken place within the last 12 hours. Now, let's go to the next test, which is creatine phosphokinase. Now, this also checks in seminal fluid only, and it can be detected up to 6 months post the ejaculation also. So, if it is a seminal stain and they want to see what, if it is a seminal stain, right, or what stain it is, they want to check it after many months. What test will they use? They'll use creatine phosphokinase. Okay. Next is PSA or glycoprotein P30. Now, this is also found in seminal fluid and it's only found in males. Very important, right? Because it's prostate specific antigen. So this is only found in males. I hope this was clear because questions can come from this very same topic. If there's any doubts, please put it in the chat. We can discuss as and when it comes up. Okay. Next. Now, this question is very straightforward and common sense question. And the reason why I feel so is because this is also dealt with under your PSM, or some people call it SPM or whatever it is. It's community medicine, right? Occupational hazards. Straightforward. It says most common mode of inorganic lead poisoning in industrial workers. Okay, so it's straightforward. You know that it is a person who's either working in a metallurgic area or someone who's working with lead batteries, something along those ideas, right? So this is a person who is working with inorganic lead and he's working in industrial setting. So what could the answer possibly be over here? Anyone in chat? Anyone have any idea? person is working in an industry, what would put this person at risk if they're working in an industry? Do you think it could be A, ingestion, or B, skin absorption, or C, contaminated hands, or D, inhalation? Okay, so Sanjay Das, you've made an attempt that it's contaminated hands. Usually, in most scenarios, you might have been right. Okay, very good, Stardust. Inhalational is possibly the correct answer here, and for a very simple reason. Okay, usually people who are working in metallurgic areas, what tends to happen is they're going to have a greater chance of small ions or small pieces of it being inhaled, right? So inhalation is actually the right answer. And as to explain as to why it's not contaminated hands, usually people who are working in industrial workers, if they had specified that it was battery, or if they had specified something where the industrial worker was actually working with inorganic lead with their hands, then it would have made sense. I would have definitely agreed that contaminated hands would have been a better option. But inhalational puts everyone at risk. Okay. And so anyone who works in a metal quarry is more likely to be at risk if we're talking about inorganic lead, right? It's more likely to be inhalational. Even though contaminated hands, I can understand why you would get confused. It's a good attempt, but when there's a better option such as inhalational, that is more likely to be the option. Okay. Next, this question was asked in July 2021, right? What is true about urinary crystals as shown in the image over here? Basically, even though the phrasing of this question is wrong, right? Look at the phrasing of this. True about urinary crystals as shown in image here. What does that mean? Right? The question is very confusing. Thankfully, there are options to give us an idea of what they're asking, and there is an image also provided. Now, with the image over here, you're able to notice that there are some stones. There are some urinary crystals over here, right? So how would you describe these crystals? Okay. These crystals, you can see that there is an X shape, right? Like this. It almost is shaped like a what? Almost shaped like an envelope. Where do we usually see envelope shaped crystals, right? Now, anyone wants to take a guess in the chat? Where are you most likely to see envelope shaped urinary crystals? Let me know if someone wants to make an attempt. Okay, Stardust very close. User Stardust has come in close, but not exactly. Okay, so the thing that you need to keep in mind here is that an easy way to remember, okay, is that there's two lines crossing, right? So, yes, very good, Sanjay, right? Bihydrate is a much better option, okay? Bihydrate would be the right option because calcium oxalate monohydrate, you would get dumbbell shape. It'd be like this, it'd be dumbbell shaped. Struvite, what is the shape of struvite? Anyone has any idea? Anyone has any idea regarding struvite crystals? Even if you don't worry. I've got a small chart here. We can quickly go through it. Very good, coffin lid. Very good, Stardust. So just quickly, we can go through this over here and you can have a look, right? As you can see over here, calcium oxalate crystals, right? Non-specific, but over here, specifically, see over here, dihydratic crystals have the envelope shape. There is an X. Whereas when we're looking at monohydrate, you have this dumbbell shape over here or over here. Okay. And struvite crystals, as you can see here, look like coffin lid shape. I hope that this was useful. Let's move on. The next question that was asked, and this one is more of a common sense question. Okay. So I want you to take a minute to really understand what is being asked over here. Okay. Now they are saying, in a case of seawater drowning, which of the following abnormalities are noted? Okay. So few things to note here. One is seawater. Already you know that it's going to have greater salt content. Firstly, what abnormalities are noted? Okay. Then they give you the option of hypernatremia, hypercalcemia, hypermagnesemia, hyponatremia, and myocardial anoxia. Now, which of these will be seen? First and foremost, we know that if it's sea water, then there's going to be increased NaCl. Okay, because obviously the person is breathing it in, it's going to go into the circulation. So what's going to happen? What happens when a extremely high salt content water enters, or solute enters into the body? What's going to happen? Right? You're going to get osmosis. And so what this causes is hemoconcentration, because water is moving from the body's compartment into the fluid compartment that is outside. So basically into the water present inside the lungs. There is movement of water. Now, if there's movement of water from the body to the lungs, then all the salt content, or whatever the solutes are, which could be your calcium, your magnesium, your salt itself, those will seem like they are relatively increased. Because the fluid content is less, it will seem like the concentration of these salts is higher. So therefore, you will have hyper of everything. So so if you just look at this, right, you look at the options, definitely there'll be hypernatremia, definitely there'll be hypercalcemia, right? Definitely there'll be hypermagnesemia. Now, will there be hyponatremia? No, we know that hyponatremia is not going to happen because everything is artificially or relatively increased. But what about myocardial anoxia? Do you think that will be there? Yes, myocardial anoxia will be there. That is also a part of drowning. So over here, what would be the correct option? You have 1, 2, 3, and 5. So the correct option would be C, right? Now, Sanjay Das felt that the option could be B. Now, because option B contains the hyponatremia option and option 1 is hypernatremia, both of those cannot coexist. It has to be one or the other. Okay. So, Sanjay, unfortunately, that is a wrong go, but it's okay. No problem. I'll explain it a little bit better with this. Okay. Assume that salt is denoted by green, calcium by red, and magnesium by purple. Now the numbers are the same in all, right? The numbers are the same in all, right? So if there's 3 here, 3 in 1, there's 3 in 2, and 3 in 3 also. Okay. Now what happens here is this is the overall amount of fluid plus salt present in the body, right? This is when the person is at normalcy. Whereas over time, what's going to happen is because there is movement of water, right? We said there's movement of water due to osmosis. And because of this movement of water due to osmosis, there's going to be an artificial reduction in the volume. So therefore, that's going to cause an increase in the salt because there is a decrease in fluid. Okay. Whereas the opposite happens in when we're talking about freshwater drowning. Freshwater drowning will have us in the opposite section because the water content is higher, right? Outside, or the salt content inside the body is higher. So therefore, water will shift into the body, and this causes increased water load in freshwater drowning, right? So this causes hemodilution. And so there'll be the exact opposite effect where everything will instead go down. So you will have hyponatremia in that. I hope this was understandable. I hope you guys got this concept. It's very simple. A lot of forensic medicine, if you understand a few concepts, you can answer a lot of things with a lot of confidence. Okay. Next, let's talk about a question that they asked in July 2021 again, right? Which is a person in police custody was placed in prone position with his wrist and ankles bound, right? And they were bound behind his back and secured by a cord. What is this method called? Now let's do elimination method. Yes, Stardust, you will have hyperkalemia in freshwater drowning. That is true, but that happens because the RBCs will rupture due to the osmotic insult that they've had. So that causes the potassium present inside the RBC to come out. And this hyperkalemia, very important that you brought it up, will predispose the person to having ventricular arrhythmias. And that obviously will cause the death in the individual. Okay, so hyperkalemia is more a feature of freshwater drowning. 100% correct. Yes. Any other questions from the drowning MCQ that they had asked? If not, I'll jump to the next question regarding this police custody. Any questions by, I think there's only two people in the chat, Sanjay or Stardust. Mechanism of drowning. Well, I'll just go back then to explaining this to you. Okay. Now, there is another question about drowning that comes up, but I will. Ha ha ha. Stardust, I need you to wait. I thought you were asking something else, but this vagal inhibition, cold water drowning, laryngospasm, I will talk about this when I go to another topic. I thought you were asking just basic mechanism of drowning. If you are asking for specifically what you mentioned in the chat, like vagal inhibition in cold drowning, laryngospasm, there is a question afterwards where I will deal with that very same topic in more depth. I thought you were asking in general. So I'll move on, but I will come back to this when that relevant question comes up. I hope that's fine. Okay. Okay. Then I'll move on to the next question. Don't worry, that question that you have asked will be answered in due time. There is another very relevant question about the same thing. Okay. Okay. Now, a person in police custody was placed in prone position with wrist and ankles bound and secured by a cord. What is this method called? We'll just use elimination method here. It's the simplest one. Falanga. A is falanga or falaka. Now, what does this? We know that it's a torture method, right? Like most of these, it's a torture method, but this is physical torture in the form of inflicting pain. Whereas what they've mentioned here, as far as the description goes, is that they have restrained the individual. Okay, so there's a difference between restraining an individual or suspending an individual and inflicting injury on an individual. Okay, so falanga is where you're beating the person on the soles of the feet. Okay, and the reason this is done is because the person shouldn't be able to walk or run, and also because bruises will come to the surface later because the skin is thick, it is cornified. So, slow bruising. Okay, slow bruising happens over here. That's one of the reasons why they will employ this torture method. Then we have carotid sleeper hold. Now, from what they've explained here in the scenario that they've provided, have they mentioned anything about any pressure over the neck at all? There is no mention of it. Okay, so we can safely rule this out because there is no question of anything happening to the carotid here. Okay, so this can also be ruled out. Falanga can also be ruled out. What about chokehold? Is there anything to do with the neck again? No. Your best option is going to be hog tying. Okay, and I'll explain why. Hog tying is also known as total appendage restraint. Okay, known as total appendage restraint. What is happening is a person will be, let's say, on their back, on their stomach over here. Okay, person's nose is here, legs are like this. Okay, their knees will be bent, the ankles will be tied here, their hands will be tied behind their back like this. See, their ankles are tied together and their hands are tied together, and then this is then tied together as well. Okay, so the actual appendage restriction will look like this, where here there'll be like the left ankle, right wrist and left wrist. Basically it's happening behind the person's back. Okay, so this is what the overall restriction looks like. Don't worry, I have a picture in the next slide to give you a much better idea if this was too confusing. Have a look over here. Okay, what do you see in these images? What is this over here? Image of a foot being hit by a stick. What is this? This, as you can see, is phalanga. This was the first option that was given. Okay, this is phalanga. Then what about the two neck holds that we have over here to the side? One over here, one over here. What are these? Well, the first one over here, if you notice very carefully, the elbow is crooked in front of the person's trachea. Okay, so over here, the person is not being choked, but the muscles of this gentleman's forearm and his arm are pressing on the carotid. So, this is the carotid sleeper. Sleeper hold. Okay, now what about this? The second one, second image over here. Have a look at it. What does it look like? See over here that the gentleman who is doing the assault, his forearm is directly pressing into the victim's neck. So here, both the carotids and the trachea both can get compressed. So the chance of the person being choked are much higher. Hence, this is called a choke hold. Right? Now, this is what I was trying to describe earlier with the poorly drawn diagram. I apologize for that. Notice how this lady over here on her abdomen, right, with her arms behind her back tied, feet also tied, and there is a connecting appendage between them as well. See, the connecting cord is also there to secure such that the person cannot run away. This was used when individuals would go hunting for wild boar and pigs. Hence the term hog tie. I hope this is clear. Yes, Stardust has asked a question. Mugging, direct pressure to the trachea. Yes, it can happen in mugging also. Correct. That is another phrase for it. Correct. Any other doubts? If there are any other doubts, you can place them in the chat regarding this question. If any of the options were unclear, if you were unable to answer it, if it seemed like there was anything confusing. Okay. Is mugging and chokehold the same thing? Not necessarily. The mechanism is the same. The mechanism is the same. Now, the chokehold, I'll tell you the biggest difference over here is that the chokehold can be inflicted in such a way where the position of the individual, the one who is doing the assault, need not necessarily be from behind or from front. It can even be with a person with mugging. It can even be that it's always with the person behind. Mugging is always with the person from behind, right? As far as we have seen. But in principle, when we use it, we use them interchangeably. Don't worry about that. Okay. So they, yes, to your question, yes, they can be used interchangeably. Any other doubts? The only time the actual difference comes between, whether it is mugging or chokehold is definitely to do with the relative positions of the people and what they are using to actually, suffocate, sorry, to limit the oxygenation of the other individual, whether they're using their hand or whether they're using any other equipment. But for all intents and purposes, yes, they are used interchangeably. Okay, let me know if there's any other doubts regarding this before we move on to the next question. Yes. Okay. Parrot perch. Now, parrot perch is a type of suspension torture, which is very common in Latin American countries, specifically, if I'm not mistaken, Brazil, where it's called something I mean, they've got the Brazilian term, Portuguese term for it. I apologize. I'm not able to remember off the top of my head. But what happens there is an individual is, I hope you can see the drawing that I'm about to do over here, where in which an individual, right, let's say his head is over here, right? This is his knee, this is his arm, right? Let's say I have his arm behind over here. Okay. Have you able to understand? This is the arm, this is the knee. Okay. Or better than arm, let's say the elbow. Okay. So what happens is they will place a rod or a stick in front of the elbow over here and behind the knee. But the stick is straight. right? The stick is straight. So imagine that you have to put a stick through in such a way where it is in front of the individual's elbow, right? But behind the same person's knee. So imagine what position the person will be in. He has to be in a squatting position with his arms behind his back, right? So they will have the person tied into a position like that, and then they will lift the stick. Now, what will happen to the individual who has been tied? He's going to be in tremendous pain. This is what parrot perch is. The person is hanging as though he's perched on a stick like a parrot. Is it clear, or you want me to explain it again? Just know that it's a straight stick. Yeah, it's called Pau de Arara. My friend is just helping me here. It's called Pau de Arara. Yeah, Pau de Arara. Okay, parrot perch. Got it? Very nice. I'll move on to the next. Okay, here. True about the burns seen in the image. Okay, so this is, you have to find out which one of the statements provided is true. Let's go through all of the statements. The first one says, it is seen in cases of lightning burns. Another one says, it is seen in 30% of lightning burns. 3, it's seen in electrical burns. 4, it is associated with thermal flame burns. Okay. First and foremost, what exactly is in the image? As you can see, there are tortuous, superficial markings, right? And it has a arborescent pattern. Okay, arborescent pattern. Now, arborescent burns or filigree burns are seen most commonly with lightning strikes. Person must have been struck by lightning. So immediately we can exclude one option, which is D. It cannot be D, right? Because we know it happens from lightning strike. But option C says seen in electrical burns. No, we do not see this in electrical burns. So this option is also removed. Now we have two options left, right? A says it is seen in all cases of lightning burns. B says it is seen in 30% of lightning burns. Now, is it seen in all cases? No, it is not seen in all cases. It is usually only seen in 30% of cases. So, option B is the correct option, right? Which is, it is seen in 30%. Very good, Stardust. You've answered filigree burns of lightning. That's true. But the question over here that they're asking, the main confusion you're going to have is it seen in all lightning strike cases, or is it seen in few? And yes, it is seen in 30%. Another thing that's very important to note is it is usually seen around the shoulder and the chest area. Okay, shoulder and chest area seen in 30% of the cases. There are various hypotheses as to what is causing it. The first one says that it is hemolysis, right? Hemolysis that occurs along the line of the force that is hitting. The second one is that it could be due to extracellular deposition of, I'll just write that, ECF deposition of copper. Okay, of copper. The third one says that it could just be direct damage to the skin. Okay, so direct damage. Okay. Another thing that you need to know over here is if the person survives, very important, if the person survives, then these marks usually disappear within 2 days' time. Right? Around 2 days' time, it will disappear. Okay. Next question. Right? Now, this also I would like for you to pay a little bit of attention because this has been asked and it's a very clever way of them making you recollect a lot of information in a very short period of time. Okay. However, if you know these tables that are provided in your textbook, if you just know these tables of the sexual differentiation, sexual differentiating features between male and female skull or pelvis, you will be able to answer this in your sleep also. It's that simple. Okay, so let's go through all of the options, but first let's look at the question. Sorry. A female skull brought by the police was analyzed in forensic medicine department. To consider this as a female skull bone, right? Which of the following features should be present? Now I'm leaving it to you guys. You tell me. Don't answer the question. You first tell me in the features. See, there's 6 features. You tell me which of these 6 features indicate towards it being female or male. If you know one, then you know the other, right? So let me know. If you're unable to answer, I'll go to the next slide and I'll show you the table. That's why. If you're able to attempt, you can attempt. Stardust says 1, 3, and 4. Square. Okay, so that's prominent frontal and this thing. Then smooth small glabella. Then square orbits. Okay. Any other attempts? That's the only one. Okay. So very close, but square orbits alone will not make. I can only guess 1, 3, and 6. Very good. Actually, I was worried that you were not answering point number 6. Okay. Don't worry. I'll show you the table which is on the next slide. Okay. You look at that, then we'll come back here. Then you have a look. Okay. Then you tell me what you think is right. Have a look at this table. Okay. So the eminences in female would be larger, so they'd be more prominent. Okay. Then is the forehead vertical or sloping? It's vertical and it's usually more rounded, like you have said. Correct. Then frontonasal angle. This has to do with the glabella again. Okay. Very clever way of just rephrasing the same thing. Okay. So here smooth. Again, you got that right also. Now the orbits. This is the part where you got confused, right? Where you were saying that it is square. No, it is inverse, right? It is square with smooth margins or round with sharp margins. You need to remember it that way. Okay. So in females, it tends to be round with sharp margins. Now, this is a small trick that we learned when we were in PG, which is you can just feel around your own eye to see, right? If you're male, it's going to be more likely that it's going to be a little bit more squarish, and you're going to feel that it's a bit more rounded, like smooth, like you will feel the dip inside. Whereas women, you can just have a look as well, and you're going to notice it's a bit more round with sharp margins. Then mastoid process, if it was given, that would have been very beneficial, small and pointed. They say in the women, the mastoid is like a pinky finger, and in the men, it's like a thumb. Okay, so that's also an easy distinction. Now, let's go back. Tell me, Stardust, which is the right option? Because you got the prominent frontal and parietal eminence. You got the narrow mastoid. That's the one you missed as well, right? Got the small and smooth glabella. Yes. Square orbits? No. Prominent cheek? No. Round forehead? Yes. So 1, 2, 3, and 4. Sorry, 1, 2, 3, and 6. Yes. Option C is the right option. Okay. It's okay. The mastoid, please remember that, right? For women, they say it's like a pinky, but for men, they say it's like a thumb. Okay. Easy way to remember. Next question. Okay. Match the post-mortem change with the time since death. Now, this question I had a lot of issues with when I first read it, because it is every textbook gives a different number. And so it can be very confusing for students, and it's a very unfair question to ask, in all honesty. But since it has been asked, let's just apply the best knowledge that we have and move forward, right? Here, when does marbling start? Okay. So just any idea of the options given here? Marbling, does it start 4 to 5 days after death, or 5 to 10 days, or 2 hours later, or 24 hours later? Let me know. I guess it's only me and Stardust. So please, Stardust, tell me. Very good. So 24 hours is the best option that we have over here. And the reason is because it's usually seen that yes, it is the best option that we have. Is there any doubt? It can be seen 18 to usually 48 hours, right? But yes, by 24 hours for sure. Okay. Now, the reason why there's so much variance is because India is a large country and we have various different uh, climatic conditions. So as many of you may know, we have a lot of seasonal changes as well. So therefore, it is very difficult to come up with a very straightforward answer saying, yes, this is definitely going to be the case. That's why we usually answer in the term of ranges. Okay. Now, that's about marbling. Yes, you've got that one right. What about adipocere? Actually, you know what? Adipocere is the one that will definitely confuse you, right? So instead, you tell me about sphincter relaxation. Sphincter relaxation, you tell me. When does it happen? Does it happen 4 to 5 days, 5 to 10 days, or 2 hours? Ah. Okay, Stardust, do you remember reading this anywhere? Okay, very good. Sphincter relaxation would be 2 hours. This is the best option. See, now you've already answered two, right? Next, liquefaction of tissues. Now, this is something which is a normal change that happens. Liquefaction is a normal change that happens, right? Adipocere requires certain conditions to be met. So, it's not always going to happen to a dead body. There might be mummification, skeletonization, other things also we have to look at. But liquefaction of tissues is something that happens because of the lecithinase enzyme, which is released by Clostridium species, which are present inside our gut. Okay. So, here liquefaction of tissues, usually they say 5 to 10 days. Okay. Now, I want you to take just 1 minute when I show you the next page because there is tremendous variance and I have taken excerpts from the textbook itself. Okay. So please do not get confused as we go through this. No, so only. No. Huh. No, so only out of the options available, I only could make a guess. Yeah, don't worry. So don't feel bad about it. I want you to go through what is mentioned over here. I've highlighted the important parts. This is the reason I said this question is not exactly fair because there's a lot of variance in different textbooks. Like for me, I'll tell you what came across as very confusing because many students came to me and they were asking me the same thing. They were asking, sir, when exactly does this thing, what do you call, the adipocere formation take place? Right? And what we are taught is that it can take 3 to 6 months, but the question over here they were asking required the answer in India. It has been observed to begin with 4 to 5 hours itself. Sorry, 4 to 5 days itself. So again, see how there's so much variance. You look at marbling of skin, I told you, right? Starts around 24 hours, prominent in 36 to 48 hours. Then we look at liquefaction of tissues. That is pretty much standard to be around 5 to 10 days. But the confusion, right, is with the sphincter. The sphincter relaxation is the confusion that all students had because in various textbooks it's given as different things. See, it says that in 2 to 3 days the sphincters relax and urine and feces may escape. Now, from in practice, from what I have seen, right, it is usually seen very soon, right? The tone of the muscle gives way, and yes, Stardust, you're right. So the tone of the muscle gives way, and there is evacuation of the bowels or the bladder. See, in practice, it relaxes quite soon. Okay. Other sphincters may be what KSN Reddy textbook is referring to, which is there are various smaller sphincters inside the body, right? And those might be giving up or relaxing much later. But your main urinary and anal sphincter tend to give up quite soon. Okay. They relax very early. Now, the exact chronological appearance, order of appearance of these postmortem changes is not always going to follow a very specific path, right? There is going to be slight variance, and that is why it is very important to keep in mind that you have to work with ranges. Okay, this question I feel was very unfair to be asked to students because I feel there are a lot of PGs also who might get this question wrong. In all honesty, if you got the answer right, congratulations. We'll move on. Okay, students, let's have a quick discussion about this, right? Match the following, right? First thing they've given is twilight state, second is honoroid state, then there's oligophrenia, and then there's paranoid. Now, options which are on the other side to be matched with are onerophrenia, persecution, subnormal intelligence, and impaired state of consciousness. Okay, just from reading this, right, you should be able to answer at least two. Okay, and those two are specifically paranoid, right? What is it when someone is paranoid? What is it when someone is paranoid? It means that the person feels like the world is against them. Okay, they feel like everyone is against them. That is nothing but persecution. The person feels like they're being persecuted against. Okay, so this matches up quite well. Next, we have subnormal intelligence. The person is not completely of normal human intelligence. The person may have little bit of mental retardation or subnormal intelligence. Their IQ may be a bit lower. Yes, Stardust. Delusion of persecution. The person is paranoid. Person is paranoid. So what is a delusion? If you do, I mean, you mentioned delusion of persecution. Yes. What is a delusion, Stardust? Any idea? You can describe it in only three words. If you know, let me know. What is a delusion? No? Okay, don't worry. I'll just write it here. False fixed belief. It's a false fixed belief. Okay. That despite the evidence of the contrary, the person continues to believe in. Okay. Even if you show them proof that their belief is wrong, they will continue to believe in whatever they're believing in. Okay. So, yes, you brought up persecution. So, this matches up quite well. Now, let's get back to the other options over here. Right. I was talking about subnormal intelligence. Right. Now, oligophrenia is the phrase that is actually used over here to denote subnormal intelligence. Oligo meaning few, phrenia meaning mind state or ability, right? So here it would be subnormal, right? So these two you should know. Now, between honoroid state, twilight state, which one is impaired state of consciousness and which is onerophrenia? Now, what is onerophrenia? Onerophrenia is an honoroid state, right? And it is the state of dreamlike, right? Just remember this of being in a dreamlike state. The person cannot really distinguish between reality and fantasy. Okay, so this is known as honoroid state. So that only leaves one option, which is twilight state, which is the impaired state of consciousness. And this twilight state, easy way to remember is they say that twilight is the time between morning and night, right? So as you're waking up in the morning, what happens? You don't know what exactly the time is. You don't know if it's night or it's morning. You don't know if you're asleep or awake. No, Stardust. I specifically said that honoroid state is onerophrenia. Twilight state is impaired state of consciousness. I have marked it on the slide. You can have a look. Twilight state is an impaired state of consciousness because see, I told you the person does not know if they're asleep or awake. What is that is literally the definition of someone being conscious or not, right? The person is conscious. So therefore, yes, very good. I'm glad there's no confusion. So I have matched the following such that you understand. Let me know if there's any doubts in these terms. If not, we'll move on. Any doubt? Okay, I'm seeing that there's no doubt. I'll move on. Okay, now this question again, match the following. Okay, they have given various options here, specifically with the medial end of the clavicle, the crista scapulae, the sacrum, the lambdoid suture. Now, few things to be noted here, right? Which is you need to know two of these at least, right, to be able to completely blow this question apart. Okay, and those two are the medial end of clavicle and the lambdoid suture because this is part of your practicals also. That's the reason it has more weightage right now. Okay, so first and foremost, the medial end of clavicle. When does it fuse, right? Don't worry, I've given it right next to it. All the answers are right in front of it only. Okay, because I understand when you're asking students for very specific numbers, especially when it comes to age estimation, it becomes very difficult. But these two you must know because they can ask questions surrounding this very same topic. Okay, Then you have the lambdoid suture, which is actually usually it's 40 to 50, and it can vary a little bit. But the reason why we have to allow this to perhaps be the answer is because ectocranial sutures and endocranial sutures have a 10-year delay. Sutures will actually fuse on the inner side of the skull's vault faster than they will on the outside by around 10 years. Okay, so therefore we have to allow for a larger margin of error. Then we have to talk about the sacrum. Now, the sacrum usually fuses, right, by around 25 years, but you can also have something called lapsed union. That means even if you find skeletal remains of an individual who might be 35 or 40 years old, his sacrum may not be completely fused. And that is because there is a very frequent feature of lapsed union. This can also be seen in, your skull sutures as well, and even the base of skull sutures as well. Okay. Now, what about crista scapulae? Right, the crista scapulae is a specific part of the scapular bone, right? And so this is the one that I can completely forgive students for not knowing. Okay, I can completely forgive students for not knowing. But medial end of clavicle, you must know. Lambdoid suture, you must know. And the sacrum, mainly because of lapsed union, right? You must know. If you know these three, then it becomes very easy to get past it. Okay, so it's straightforward. Correct, you're right, Shadini. It's straightforward, top to bottom. I've arranged the options also as such that there's no confusion. This table acts as a revision for you, rather than for you to rack your head so much, because it is sort of an unfair question that they ask direct values from things that you might not be applying on a day-to-day basis. So we'll move on to the next one. Okay, this question is one of my favorites, right? A 25-year-old athlete collapsed and died suddenly. Okay, keep this in mind. 25-year-old athlete collapsed and died suddenly. Okay, so this is a sudden death. The dead body was brought for autopsy, and when seen during autopsy, the heart looked as shown in the image. It's on the next slide. I'll show you, but we'll read the question first. Okay, which of the following statements is true regarding this statement? Don't read any of the statements. See the image first. Okay, have a look. Now, what do you see in this image? I hope you're able to tell the various parts, right? You've got your left ventricular wall over here. You see it, it's nice and thick, right? You're able to see it, it's nice and thick. Now, I hope very good. You see hypertrophied LV, banana shaped heart, not exactly, but what do you see over here? What is this? You're able to see this highlighted part in between. They have cut the heart right down the middle. They've just gone along the long axis. So, what is this part? There is symmetrical hypertrophy. Do you think so? If there was symmetrical hypertrophy, it would be considered ASH. No. Okay, so I'm surprised you are not able to note this, but let me just quickly tell you. Okay, you are able to note that this is a chamber, right? Stop guessing. Tell me if you're able to identify that this is a chamber. This is a chamber and this is a chamber. You're able to notice? Just a yes or no question. Are you able to understand that this is a very good? Okay. So the reason why I'm saying that is if it is a chamber, then it has to be covered or bounded by walls, right? So what are the two walls? Or what are the four walls that you're going to see if we're talking about the left ventricle? Left ventricle, what are the walls that it will have? This one will be the same, no? This is the left ventricular wall, correct? What is this wall here? Very good. That is the IVS, right? But what would be up here then? Up top, you would have the what valve? Very good. Mitral valve. Very good. Okay. But when we're talking about in reference to this, this is clearly the IVS. So there is hypertrophied IVS as well. Okay. So hypertrophy has happened of the IVS, right, along with left ventricle, right? So obviously there is a myopathy. What sort of myopathy could be here, right? Cardiomyopathy, but what sort? What type? What has happened to these muscles? Have they increased in size or have they increased in number? What has happened? This is questions from pathology. So I hope you guys will be able to answer this one. Size increase, very good, which is also known as what? Hypertrophy, right? So this is, yes, very good, Stardust. It is hypertrophic cardiomyopathy. Now, this question is not completely forensic medicine, it is forensic pathology as well. Size alone has increased. Very good. Let's have a look over here at the question all over again, right? So, going through this, we can see that the options provided were sudden death due to atherosclerosis. Is that what has happened over here? Absolutely not. There is no atherosclerosis at all. Okay, because none of the vessels have been shown to us, we cannot talk about atherosclerosis. There's no yellow plaque seen anywhere, cannot comment on that. Next, we have sudden death due to arrhythmia. Is it possible? Yes, it's possible, but unlikely. Okay, then we have sudden death due to HOCM, hypertrophic obstructive cardiomyopathy, right? Pranav Mohanan thinks the answer is sudden death due to arrhythmia. See, I'm not saying that arrhythmia is unlikely in cases of HCM. There is a chance of it. I'm not saying no. But please look at the other options also before just jumping in and answering. Right? Look at the other options also. Right? You look at this. Sudden death due to HOCM is a much better option. Okay. Sudden death due to atherosclerosis, same option as A. Okay. I think one of them was supposed to be arteriosclerosis. That would also be wrong. Okay. So the best option here would be C, because we saw that there was HCM. Now, the reason why I am a little hesitant to say that it is HOCM is because the O part is obstructive. The O part is functional. You can only notice that it is causing an obstruction when you see like an S-shaped interventricular septum that you can see functionally getting in the way. And you cannot make a functional diagnosis at autopsy. Okay. At autopsy, you can only comment about the gross issues. Okay. Sudden death of young athlete. Yes, very good. Like I said, this is most commonly seen in very young individuals. Usually they're athletes. They tend to have higher muscle mass. Now here, sudden death has happened in this individual. But why has HOCM occurred in this person? Because there is a genetic predisposition. Hence, we must screen the family members to keep any of them from having any sort of risk of sudden death moving forward. So the best option here is option C. I'm glad a lot of people in the chat have answered this correctly. Very good. You guys have at least been paying attention in pathology. Very good. Let's move on. Okay. Now, this is from November of 2021. We'll start moving a little bit faster over here. Okay. Let's pick up the pace. Cool. Two friends meet up. Okay. And get into an argument over a common girlfriend. Okay. Following which, one friend kills the other by sitting on his chest and covering his nose and mouth. This is an example of what? Anyone has an idea in the chat? Stardust thinks it's Birking. Okay. Very good. Any other attempts from anyone else? Very good. I'm glad all of you have answered it correctly. Yes, 100%. You're very right. It is Birking. Birking is nothing but the combined effect, right? Combined effect of traumatic asphyxia and what? Smothering. Okay. Smothering is nothing but you're covering the nasal apertures and the mouth. Okay. Traumatic asphyxia, they've given as one of the options. Smothering, they've given as one of the options to confuse you, right? Please do not get confused. It is the combination of both of these. Now, also very important to ask you, what is overlaying? Anyone has any idea what is overlaying? Any idea what is overlaying? This question has been asked before, so you should know about it. Okay. Since nobody is attempting, I'll just quickly tell you. Overlaying is, oh, very good. Pranav is attempting. Okay, very good. Okay, so yes, overlaying is seen, yes, with young babies. Yes, very true. It's usually, yes, mother overlays the baby. Very important to note. Thank you. Stardust has answered more accurately than the rest of you. You are supposed to mention who is overlaying, right? The mother usually in her sleep will turn over, right? And she lays on top of the baby, causing the baby to asphyxiate and pass away. Okay. Someone earlier has mentioned positional asphyxia. Positional asphyxia is not the same. Positional asphyxia is when the person who is in question, usually inebriated by alcohol, is in a position where their head is down, right? They're in a head down posture. So, what happens is the diaphragm cannot expand effectively. And sorry, the diaphragm cannot expand effectively and cause the ribs to expand and cause negative intrathoracic pressure to draw air in. So, the person suffocates because abdominal contents are pushing on the diaphragm, not letting it expand the chest. So the person passes away due to that. That is positional asphyxia. Person is either in a head down position or a jackknife position, it's called. Okay. Or a knee to chest position, sometimes they call it. Okay. I hope this was helpful. Head down position or jackknife position. I'm very happy that you guys answered the Burking thing. I'll just show you a very famous image, right, of these two individuals. You notice one person over here sitting on this person's chest, one person smothering. See over here, he's holding the nose and covering the mouth. Okay, and he's doing this in an attempt to basically kill this person because I don't know if you guys know of the history behind this. These two individuals were doing this for the purposes of donating this dead body to the medical colleges. They were doing this because they were paid for donating dead bodies, especially if they were fresh, for anatomical dissection. So that is the history behind Burking, hence it is named. You have read about it, very good. Okay, next question. Let's quickly get to this. A person disappeared, right? And 2 weeks later, at an empty lot, a skeleton was recovered by the police, and the pelvis was identified as male. Which of the following features suggest male pelvis? Now, you guys tell me in the options given here which of these features point towards it being male and which point towards it being female. Any ideas? Stardust thinks A, E, and F. Very good. E and F, I would have expected all of you to be able to answer this. You must know it, okay? Because these two are very, very important features to be able to say that it is a female pelvis. But there is one feature that Stardust forgot to also mention, because there are three main features actually to say that it is female just by looking at it. And that is that U-shaped pubic angle. The subpubic angle, right, in men tends to be acute like this, and in women tends to be more smoothened out, right? It's less acute. So B is also that. Okay, what about the ischial tuberosity? Okay, very simple. I don't want any of you to get confused. Just picture a complete intact pelvis with two innominate bones and one sacrum, right, in your head. Just understand that when you say it is a female pelvis, that the baby's body has to travel through it. Mainly, the baby's head has to clear the pelvis. So from the inlet to the pelvic outlet, there needs to be a smooth passage for the baby's head. So will the ischial tuberosity be pointed inwards or outwards? You tell me. If the baby's head has to travel through without tearing, without getting damaged, will the ischial tuberosity be inwards or outwards? Very good, Stardust. So hence D also points towards it being female. What about the obturator foramen? Okay. Obturator foramen, will it be oval or triangular? So it's usually in such a way where assume that the default is it is oval, right? But in women, what tends to happen is the upper brim has to widen out to accommodate the baby. So therefore, you have the shape which is initially like this getting squished down. So you end up with a shape like this, which makes it look more triangular. So therefore, we have a triangular obturator foramen. The only feature over here which points towards it being male is most likely the large acetabulum, because in women you have a smaller acetabulum. All the other features point towards it being female. Okay, now I'll show you a table so that there's no confusion. You can just go through it, right? But please commit this table to memory. It's a very high yield table. Okay, specifically that your preauricular sulcus in females will be broad, deep, and it's usually present. In men, it may be absent, right? Subpubic angle, we talked about this. Men, it's V shaped, in women, it's U shaped. Greater sciatic notch, narrow and deep in males, wide and shallow in females, right? The sacrum has uniform curvature in males, whereas for women, it goes down and then slightly bends forward, right? So the upper half is straight, lower half is curved. Okay. Kylotic index, more sacral in men and more pelvic in women. Okay. I hope that that was useful. Now we're moving on to the next question. Okay. While conducting the autopsy of a victim of hanging, okay, already you know it's a case of hanging. The victim is seen to have a protruded tongue. Okay. He was found with his head hanging to his left side with saliva dribbling from the left angle of the mouth. The right eye is opened and the pupil is dilated. Compression of which of the following structures is probable reason for this open eye that we see? Okay, Stardust has quickly answered it. Very good. 100%. It's right. What is this feature known as? Very good. Left. Yes, sympathetic facies is exactly what it is known as. Let's go through it very quickly from the process of elimination, right? Can it be internal carotid or internal jugular? No. Vascular changes are very unlikely to cause neurological results, right? So both of these options are removed. What about the left vagus nerve? Yes, we could consider it. However, left vagus nerve's influence on the eye muscles is not exactly the major concern that we have, and it is a parasympathetic, right? This is more likely to be what is happening. Okay, so cervical sympathetic chain is the right answer. Now, just over here, have a look. Autopsy findings externally that you'll see in cases of hanging. Okay, so first and foremost, you have congested cyanosed face and nail beds. Okay, you'll have congestion in these places. You'll have small hemorrhagic spots, which are known as Tardot's spots. And these are seen over the eyelids, in the subconjunctiva, and also sometimes in the forehead as well. The protrusion of the tongue out of the mouth and the dribbling of saliva and le sympathetic are all things that you are very likely to see. Protrusion of tongue by itself is not antemortem or postmortem. Okay. However, very important for you to note is that dribbling of saliva happens only in antemortem hanging cases. So, very important feature for you to note that if there is dribbling of saliva that is happening because you're having the knot of the ligature material rub against the. Yes, that's why I'm telling you this. Yes, that's why I'm explaining this, ma. So you have the knot which is rubbing against the submandibular gland, causing a reflex salivation or hypersalivation, right? That can only happen if the person is alive. So it is antemortem. Laphasia sympathetic, yes, happens in antemortem only because you need an intact nervous system, right? It cannot be there if the person has passed away. So therefore, yes, it can help differentiate between antemortem and postmortem. It is seen in antemortem cases only. Okay, so these two features you must remember, very, very important. Okay, very good. So dribbling of saliva, surest sign it is. I just explained it, right? Why does it happen? Pressure on the submandibular glands, opposite side of the knot due to gravity. The knot will be on this side, dribbling will happen on this side because the suspension is on this, right? Suspension pulls on this side of my head. this side of my neck, and so dribbling will happen towards gravity. Okay. Le facies sympathetic or sympathetic facies, right? Here, note here, the knot presses on the cervical sympathetic chain, causing the eyelid of the affected side to remain open and pupil to be dilated. The person is dead, yet this place remains dilated. Okay, the eye remains, the pupil remains dilated and eye remains open. And this is also an antemortem sign. Okay, so I hope that was helpful. We'll move on. Okay, again, match the following. Any attempts? I mentioned earlier that fingerprints as a question tend to come up quite often. Okay, Stardust thinks it's B. Okay, 2B, 3A. Okay, cool. Very interesting. Sami feels it's D. Okay. Hmm. Any other answers? Any other answers? No? Okay. Now, if you were, no worries. If you were listening, at least during my earlier classes, I would have taught you a mnemonic called R leg, right? The right leg. But if you haven't, don't worry at all. I'll show you a table, then we'll come back to this. We'll answer this together, okay? Because I don't want any of you feeling confused. Shadani feels it's D. Don't worry, I'll show you the table. Have a look, okay? If there's permanent alteration, right, of the fingerprints, that's usually seen in leprosy and electrocution. Can also be seen in radiation poisoning and screen grafting and scleroderma, okay? Whereas ridge atrophy, if it's permanent or complete, is seen in celiac disease. Whereas with dermatitis, you get incomplete, right? You get incomplete ridge atrophy, okay? Excuse me. So I want you to consider here, right? Please remember this mnemonic, this R leg, okay? Please remember this mnemonic, can be very useful. And I think these two you'll easily be able to remember that celiac disease and dermatitis will cause atrophy of the ridges. One is permanent and complete, the other one is incomplete. Okay. Now I'll go back. Okay, what do you guys think the answer is now? Dermatitis is complete or incomplete? Very good, Stardust. Very good. It is straightforward. I have kept it very straightforward. Okay. The answers are direct opposites because I'm aware that many of you are using this to try and do like a last minute revision. So I've kept a lot of these match the followings as straightforward. Okay. Very good. Yes. Incomplete atrophy of the ridges. B. Radiation poisoning causes permanent atrophy of the ridges. Scleroderma causes altered ridges. And celiac disease, permanent loss of fingertips. Okay. So we'll move on. You can go through this once more if you want. Quick revision. Okay. Now, next question. Okay. Which of the following rules are used in a case of insanity to test insanity? Okay. Which of these following rules are used to test insanity? Sarima, Stardust, chemical injury. Did I? No. What chemical injury specifically? If you're talking about corrosives, unless the burn has reached to a very deep level, it's unlikely for it to cause complete loss. No, chemical injury in general will not cause. So you need to understand what this means when they say, okay, I can understand this confusion, but quickly I'll discuss this. When they say that there is complete loss or when there is partial loss or whatever it is, the finger is still intact. The finger is still intact, but the ridges are gone. So therefore, when the person applies the fingerprint, there is no print. So that's why we're looking at that. When you're talking about chemical damage, what happens is, if it is shallow enough, right? If it is shallow enough, then there might be temporary loss of certain parts of the ridge, but it will not cause complete damage. Complete destruction will not happen. Okay, cool. Now let's get to this, right? And this question has been asked twice, right? Which is, which of the following rules has been used as a test for insanity? Now here they have Durham's rule, Curran's rule, Ashby's rule, and Murphy's rule, right? So immediately, I hope you guys know that all four of these cannot be. Okay, so this option not possible. 1 and 4, right? People are saying is Durham's rule, Murphy's rule. Okay, Stardust, you're saying that the answer is is D, 1 and 2. Okay, Shabir. Okay, very good, Shabir. That is the correct answer. Okay, Durham's rule and Curran's rule are the correct answer. Ashby's rule doesn't exactly come under this. There is an Ashley's rule, okay, but that comes with respect to the sternum, okay, and 49 millimeters measurement. The length of it being more or less tells you whether it's male or female. That is Ashley's rule. It has nothing to do with insanity, so I don't know why it's there. Murphy's rule again does not come in this at all. No, that is Ashley, not Ashby. Yes, very good. I'm pretty sure it's Ashley's rule, but I'm glad you made the connection. It's very good. Just have a look over here of all the various tests that do exist, right? So we have something called the irresistible impulse test. This also has another name. Let me know if anyone else has an idea of what that name is. The irresistible impulse test, okay? Which basically says that at the time of the incident, the individual was driven to an impulse, right, to perform an act, and hence had diminished capacity to resist. Person could not control themselves and committed an action, is what they're trying to say. Then we have Durham's rule, where they say the crime was a product of mental health or mental disease or defect. Now the problem with this is, how do you define product, right? So this also was put aside. Then we have Curran's rule. Curran's rule says that the accused is not criminally responsible if at the time of committing the act he did not have capacity to regulate his conduct to the requirements of the law. See how cleverly they have worded it, to say that because of mental defect or disease, the person was not able to regulate his conduct. Okay, so again, that also became a question: is what exactly is this person saying? Okay, now I hope you have understood here. These are tests for insanity. Stardust, you have asked about McNaughton. McNaughton's rule is different. That is what gave rise to our section 82, 83, and 84, right? All of them, where basically we're talking about the fact that a person who, at the time of committing like committing a crime, right, cannot be held responsible if at the time of committing it he did not know that what he was doing was wrong, or that the consequence of what he was doing would be wrong, because of the fact that he has a mental illness, or because of unsound mind. Okay. Any other questions? I had asked if anyone knew about irresistible impulse test. It has another name for it. Anyone has any idea? It's named after a place. Okay, you guys check out New Hampshire. Sorry, New Hampshire. New Hampshire. Okay, please check out New Hampshire test. Okay, no worries, no worries. Fair enough. Next. A worker at a dye factory consumes a substance leading to throat pain, pain in his mouth, vomiting, blood in loose stools. Which poisoning do you suspect? Now, if you have gone through toxicology, you will be able to rule out a lot of these answers. Okay. First and foremost, they have told you that there is vomiting. Now, is the vomiting luminous? Is the vomit content, is it luminous? Is it glowing in the dark? Right? If it is not glowing in the dark, then phosphorus can be ruled out, because phosphorus gives rise to smoky stools or luminous stools sometimes. That's why sometimes it's called smoky stool syndrome, right? Smoky stools, which are luminous, right? Potassium permanganate is corrosive in action, actually, right? Especially on the mucous membrane, it has a corrosive action. Okay. Now, and here the blood is in the stools. It's not present in the mouth, right? Because the person, if you had taken potassium permanganate, mucosa of the mouth only would have been affected first. Then we're talking about thallium. This is more of a chronic presentation if it does. And usually you will have more neurological signs, CNS signs, right? Lead carbonate, yes, can be seen because it's a dye factory, right? Lead carbonate, yes. But the problem with lead carbonate is it does not present with GI symptoms usually, right? You'll usually have something like facial pallor. You'll have hematological signs and neurological signs way before. You might have glove and stocking neuropathies. These things you might have first. So therefore, the best answer will be arsenic, right? Correct. Arsenic is the right answer. Okay. And keep in mind, one very important thing about arsenic is it gives you a cholera-like appearance, right? Because it also causes acute GI, acute GI symptoms. Okay. So sometimes it can even give rice watery stools looking like, right? So it presents a lot like cholera, which is why it was often used as an ideal homicidal poison because it mimics natural disease. Very good. Next, patient presents with a burn injury, right? On the thigh with a clear track of the wound over the medial side of the right thigh with erythema, sorry, blisters and line of demarcation. It says soddened. What is the probable cause of the burn? This is a very easy question, right? Just for a second, think about this. There's a burn injury. So clearly it has happened due to some sort of heat being applied. Okay, we know it's a thermal injury. On the thigh with a clear track, they're saying a track of the wound over the medial side. When will there be a track? If the heat applied is moist, there has to be some fluid. Fluid, once you throw it on someone, it will land on the body and dribble down because of gravity. So there will be a wound track. You'll be able to see a spillage pattern, right? So therefore, we already know that it's a type of moist heat. But just because it is moist heat doesn't mean that it cannot be chemical, right? If someone throws a chemical on a person, that also will have a splash pattern, that also will spill down. So how are you guys saying that it's not chemical burn? Because in a chemical burn also you can get erythema, blisters. You tell me why it is not chemical burn. I'm giving 5 seconds. After that, I'll answer the question so we can move on. Okay. Why is it not a chemical burn? Everyone is saying that it is A. Okay. But why is it not D? Any idea? Stardust is saying that there is clear demarcation, it must be chemical. Okay, I'll answer this. Okay. The biggest way or the easiest way to tell the difference between a chemical burn and a moist heat burn, whereas scalds, is you have to look for the red line, right? This line of demarcation that they're talking about is the red line, okay, which you will see in moist heat, but you will not see in chemical burns. Okay, you can go back and check in your textbooks as well. You will not usually see it because the damage that happens to that point, right? There is no surrounding area of erythema. Whereas over here, they've even specified that there is erythema, pointing towards it being moist heat. Okay, so this is a very small distinction, but very important. You should know about this. Okay, know that in chemical burns, there is no red line. Okay, and you're very unlikely to have erythema also. The damage happens deep into the tissues, right? So at site and wherever it's spilling. Whereas with scalds, what tends to happen is the surrounding area will try and limit the damage. That's why you'll have the red line because the body is having its inflammation. Sorry, bad luck, Stardust. It's okay. You've been answering everything else pretty accurately. Don't worry. We move forward. You can just have a look over here. See, given this table, right? When we're talking about moist heat, once you throw it on someone, it'll land at the site and go below. That can happen in chemical also. If someone throws a chemical, will there be splashing? Yes, both for moist and for chemical, it will be there. Now, what about vesicles, right? Vesicles or blisters. Where is that more likely to be seen, right? That is also more likely to be seen in moist as compared to chemical, right? The red line will be present here, not present here, right? Then what? Singeing. That's a big differentiating point between dry and moist and chemical. So you can split between those two based on the singeing. And what about scarring? Very important here as well, which is in chemical burns, you'll have a very thick scar, whereas in moist burns, you'll have a very thin scar. I hope that this was helpful. We'll move on. Are there any other questions before I move on? Okay. Next question. A patient presents with injuries. The doctor was able to note a lacerated wound of size 4 into 0.5 centimeters into bone deep in the scalp region, right? Which of the following is correct regarding the mechanism of this lacerated wound? Options given here. A. Soft tissue has been sandwiched between the weapon and the underlying bone. B. Impact on a semi-sharp object with heavy force. C. Shearing force. D. Overstretching of skin and subcutaneous tissue. Now, before you attempt to answer, I'm sure some of you would have already gotten the answer. Let's go through what sort of lacerations occur due to the given forces over here. If you have overstretching of the skin or subcutaneous tissue, what are you going to have? You're going to have a stretch laceration, right? Stretch. If you have shearing force, something is pulling against, you're more likely to have an avulsion type laceration, right? Or sometimes known as flaying. If it has ripped from the bone, then you call it flaying. Impact with a semi-sharp object with heavy force. Yes, this can also cause tearing. This can also cause it. Yes, definitely. But this has happened on the scalp or the forehead, right? So semi-sharp object, if it's hitting with heavy force, then what sort of laceration you will get? Any ideas? Any ideas? If there's an impact of a semi-sharp object with heavy force, what sort of laceration you will get? Very good, man. Split laceration. This is why I was asking, because Shabir, you're right. Split laceration is correct. But option A is also explaining the same thing, no? Here they've added semi-sharp to make it seem like it is unlikely to cause split and more likely to cause a tear, right? A tear, like a clear cut laceration where there's a bit of flaying, avulsion, or skin tags, or skin peeling, or a flap that is created, right? But actually speaking, because it is semi-sharp, it is likely to cause the same mechanism as option A, which is a blunt object hitting and causing the splitting of the skin. Why? Because it's causing a heavy object from outside to sandwich the skin between the bone and itself, causing the skin over there to split. This is most commonly seen in the forehead and scalp regions. And the reason why this question has been asked, and it's been asked multiple times, is because students easily get confused between split laceration and incised wound. Because when you look at the edges of the wound, it almost seems like it's smooth. It almost seems like it is a cut margin. Okay, don't get confused. If they say any sort of blunt injury in the history is mentioned and they show a picture around the head region, most likely it is going to be a split laceration. Okay, make sure you look at the picture, see if the edges were approximated, what it would look like. But most commonly, the injury will be around the head region, and they want you to get confused between this. Another thing they'll call it a split laceration is incised looking laceration. That is another phrase for split laceration. Again, just to confuse you. Okay, don't get confused. Split laceration is also known as incised looking lacerated wound and often confused with an incised wound. Okay, I'm glad many of you have answered this correctly. Let's move on. Only ends will be a little correct. Sorry, excuse me. Correct. Roy the gamer, you're right. Okay, question number 9, right? Following a blast, a man was brought from the scene to casualty with multiple small puncture wounds on the right side of his chest, below the nipple, multiple small abrasions and bruising over the left lower abdomen. Okay, which of the following mechanisms is responsible for these injuries? You're welcome, Roy. Small tip if you want to know that also. Usually, one other very easy way to tell the difference between an incised wound and a lacerated wound is that in a laceration, sometimes there'll be tissue bridges between the edges of the wound because it is a tear, it has not happened completely. So sometimes there'll be some skin or tissue between both ends, whereas incised, you're cutting. So you won't have anything in between. You would have clearly cut through. Okay, Shabir, very good. It is flying missiles. Because if it was blast, you would have the blast wave, right? Or the air wave. And that is going to cause all the person gets pushed and all the hollow viscous inside the body. Whereas places where there is different tissue densities, or when you have air and water interface, these kind of places are more likely to get affected by blast wave. Okay, because it's a shock wave through the air. Building collapse is masonry damage, right? Damage happening because the building is falling on you. Very unlikely for it to cause all of these things. Then burns, yes, because of the extreme heat that is emitted from the epicenter of the bomb. Yes, it is very likely the person may get burns, but nowhere in the question description have they mentioned anything about burns. Flying missiles is the thing. I am so happy that someone over here has tried to attempt. The spelling is wrong, but you're in the right area. It's called Marshall's triad. Some places they'll write it with a single L, okay, but Marshall's triad, okay. I discuss it more in the next slide, so you guys can have a look, okay. Just consider this for a second. This is what it'll look like when there's an explosion. Notice from here there's an epicenter. It's all in all directions the force will be transmitted, travels through. Person is standing here, this is the blast wave, right? Moves forward, hits the individual along with small pieces. This is the flying missiles coming and hitting the person. These yellow pieces are the flying missiles. Also the debris, the cement, all the intervening objects that have been damaged will also get pushed towards the person who's standing there, hitting them, causing various injuries. Person will get pushed back. This is body displacement, right? And finally, there might be fire, chemical, or radiation injuries also which occur. Okay. Sorry, let me just Marshall's triad because you mentioned it. Marshall's triad is nothing but a combination of three things, right? Any idea what those three things are? Anyone has any clue? It's all of your blunt force mechanical injuries, basics, right? You're going to have abrasions, okay? You're going to have contusions, okay? And you'll have punctate lacerations, okay? This is very important. Please make a note of this. I don't want students getting confused. Yes, ma, but lacerations need to be punctate lacerations, okay? That's the one thing that will help you distinguish a little bit, okay? Abrasions, contusions, punctate. Bruises need not be punctate. The reason being is because bruises are usually not very well demarcated, right? It's one of the hallmark features of bruises is that they're not very well demarcated. So, punctate lacerations more likely. Okay. Okay. We move on. Sorry. Now, next question. Which of the following features is associated with Korsakoff psychosis? I am allowing for all of you to attempt. You let me know what you think the answer is. Do you think it's A, global confusion, B, ophthalmoplegia and ataxia, C, peripheral neuropathy, or D, amnesia? What is associated with Korsakoff's psychosis? Okay, very good. Amnesia not a feature. Then this is saying which is associated. So fine. If you want to go by elimination, fine. Roy, no issues. You can do that. Okay. Confabulation, right? It is due to vitamin B12 deficiency. Fine, sure. No worries about that. I'm asking what you guys think the answer for this question is. Because see, they've given quite a few things here, right? But they said global confusion, ophthalmoplegia and ataxia, peripheral neuropathy and amnesia. So which would you attempt? Stardust is saying that it's D, and sorry, is saying she's gone for D. Roy is saying D is not the answer. No worries. I'll show you a mnemonic. Okay. You think it's A? Amnesia is seen in both Wernicke's and Korsakoff's. Okay. Amnesia may be seen, ma, but what they're asking here is what is associated with the psychosis, right? So in the sense, what is the one of all the options here, which is the one which is most suitable, right? You have to pick the single best response. Okay, I'll give you a mnemonic. Okay. No, no, it's okay, it's okay. Just go through this mnemonic very quickly. Okay. This is the co-track mnemonic. Okay. C for confusion, ophthalmoplegia, ataxia, thiamine deficiency. Okay. R for retrograde amnesia, anterograde amnesia, confabulation, and Korsakoff. Okay. So the question that was asked was about Korsakoff, right? You guys had a look at the mnemonic. I'll go back and then you guys can attempt again. Okay. See over here. Confusion, ophthalmoplegia, ataxia, thiamine deficiency. Whereas over here, retrograde amnesia, anterograde amnesia, confabulation, Korsakoff. So let's go back. What is the right answer then? Which is Roy, which is associated with. If it is what is associated with, then you are right. It would be amnesia, right? It's autocorrect. Okay, fine, no worries. See, amnesia is the one which is most likely to be associated with it, right? Because you have anterograde, retrograde, confabulation. What is confabulation? The patient is not able to recollect the facts correctly and fills in the gaps with their own ideas, right? Or with their own thoughts or with their own imaginary whatever. They basically fill in parts of the truth that they know with lies because they're not able to bridge parts of their memories. So this is what confabulation is, right? So there's anterograde amnesia and retrograde amnesia as well. So this would be amnesia as the right answer. So Stardust, you were right. Uh, Roy, keep in mind this mnemonic, and let's hope that next time if they ask this, you never go wrong. Okay? No, no, it's fine. It happens. That is, Stardust is mentioning that she gets confused for well-read topics as well. Yes, it does happen. This is where the actual test is, right? This is how they know. This is how they know whether you are well prepared or not. Because if everyone has studied and gotten a seat, then where is the competition? So this is how they, try and delineate or distinguish between the candidates over time. Okay, so don't feel bad. There's still a lot of time. You can go through this again. You can watch all of these live sessions again. All of the faculty are great. Okay, and everyone's rooting for your success. Okay, so we'll go on to the next question. Okay, post-mortem examination of patient reveals the following. What is this finding known as? I think all of you will know this. There is no question. I don't even need to say anything. Very straightforward. Please answer this. Is it a pattern bruise? Is it a laceration? Is it a grazed abrasion? Is it a hesitation cut? Very good. I'm not even going to entertain beyond this. It is a hesitation cut. Very clearly you can see that this person is cutting themselves. This is self-harm behavior. Now, what are the other things that will help you say that this is definitely hesitation cut? I want you to note one thing, right? They are usually multiple, right? They are parallel, right? Superficial cuts, right? Which is incised wounds. They are multiple, parallel, and superficial. These things you need to remember, okay? And they're almost always in the same direction. Almost. It's not a be all end all rule. Sometimes they may have variation because hesitation cuts don't always need to be on the front of the wrist. It can also be on the side of the neck. It can be on the chest. We have seen many cases where people will do that. Always keep in mind it is a place which has to be accessible to the assailant or accessible to the person who is inflicting the wound. Okay. Stardust, you have a question regarding ligature marking. Is imprint abrasion or pressure abrasion? Okay. Yes, Roy. Absolutely right. Stardust has a question. I'll answer it immediately. She's asking whether ligature marking is an imprint abrasion or a pressure abrasion. Ligature marking, you note this forever. A ligature mark is a pressure abrasion. Okay, it is a pressure abrasion. However, if the ligature material they have used has a pattern, right? Like if you look at your normal clothes hanging rope and someone applies that on their neck and they've hanged themselves, over time, what will happen is that ligature material will press on the neck and it will leave its pattern on the skin. So that because the pattern is going to help you identify the weapon, if the option of patterned abrasion is there, it would be a better option, right? Patterned or imprint abrasion. Now, even in books, they say, what is the difference? Should it be imprint abrasion or patterned abrasion? Okay. And some people say that pattern abrasion is when it is like usually blunt injuries or like it's superficial, and if it's impact, it's usually because there's some rough force. No, no. They are interchangeable terms. I have seen many textbooks use this term for this and this term for that. Okay. It is interchangeable at most. Most textbooks will usually have the headings one after the other saying imprint abrasion and pattern abrasion. Please do not get confused. Okay. But ligature mark on the neck is going to be a pressure abrasion. Do not get this confused. Okay. I hope that that is clear. Okay. And we'll move on to the next question. Okay. Now, this question a lot of students had difficulty with, but it's actually quite straightforward. Okay. Because over here they're asking to examine vaginal cells on a rape accused, which of the following tests will you use? Now, if you remember the very first question that we were talking about, right? What does the Florence test help to identify? I hope you guys remember, right? It helps to identify choline, right? That's not specific at all over here. Then you have toluidine blue. Will toluidine blue be used here? Stardust is confident that it's toluidine blue. Then there is Lugol's iodine as an option and precipitin as an option. Now I'll tell you, because Stardust has attempted toluidine blue, I will not remove it as an option yet. Okay. Instead, I will talk about precipitin for 1 second. Just think about precipitin, right? Precipitin is a species-specific test. Species-specific test. It's basically used to determine whether some specimen is of human origin or non-human origin. Okay, it has nothing to do with vaginal epithelial cells at all. Okay, now vaginal epithelial cells contain what special component? They contain glycogen. Okay, and if I need glycogen to light up when I test it, what chemical should I put in it? What will help me find that there are glycogen reserves in a cell? What should I apply? Toluidine blue, or should I apply Lugol's iodine? Will iodine or toluidine help me determine whether there is glycogen present in the cells? Yes, Roy. It is Lugol's iodine. Stardust, unfortunately, you are wrong, right? It wasn't toluidine blue, but I am glad that you brought up toluidine blue because I don't want others to think that she is completely wrong. She is not. Toluidine blue is very helpful in being able to delineate micro trauma. So if there are small scratches, small abrasions, If you're able to connect back to ophthalmology, even when there's a corneal abrasion, I'm pretty sure they use toluidine, if I'm not mistaken. I think they use it there also. But whenever there's a damage to the mucosa or any sort of epithelial layer, you can apply toluidine blue to better demarcate the injury. Okay, so I hope this is very clear. I'll just show you the explanation over here so you don't get confused. Lugol's test basically detects vaginal epithelial cells present on the penis after insertion into a vagina. The principle here is that iodine stains glycogen brown, vaginal epithelial cells have glycogen, and penile epithelial cells do not stain because they do not have glycogen. Okay. Now, the color changes towards brown. Okay. And sometimes it's also called as a 4-day test because they say that the person who is the accused, if he has not showered or cleaned himself, then the test will ring positive even 4 days later. If we were to check the person 4 days later, then also if you swab the penile shaft, the person is likely to be positive for it. Keep in mind, this is if the person is not washed, has not changed. Okay, but this does not prove that rape has taken place. Very important for you to note, because even in normal sexual intercourse, consensual intercourse, there also you can have vaginal epithelial cells on the penile shaft. Okay, so don't get this confused. Stardust test, what is this? I even remember that I've had to mark it Lugol's iodine, connecting it to. Yes, it's fine. It happens. Don't get disheartened. Okay, we all make mistakes and learn. All of your professors who are teaching on this platform and even in your college or even in your coaching center, wherever you are, everyone has made mistakes to get to where they are. So don't get disheartened. Okay, you will definitely remember. See, now that you've gotten it wrong, even after such preparation, the next time this question comes, you definitely won't get it wrong, right? Because now it's formed a memory for you. Okay, so don't get disheartened, it will be completely fine. So let's move on. Right, next, treatment of choice for acute arsenic poisoning is what? Okay, now let's go through the options. Immediately you'll be able to remove quite a few things. Okay, acute arsenic poisoning, acute arsenic poisoning, and it says treatment of choice, not just any treatment, treatment of choice. Okay, very important. Epicac is used usually when it's a ingestional poison, right? And when you need to make the person vomit immediately. Okay, this is used more in terms of first aid. Okay, Epicac. Penicillamine is the treatment of choice or the drug of choice when we're talking about copper poisoning. Okay, that's D-penicillamine. Activated charcoal does not work against heavy metals. Okay, so it's not even an option, which leaves only one thing, which is dimercaprol. Okay, so this is the right option. So purely by elimination, you're able to get to the right option. The only thing that could have confused you here is penicillamine. Okay, but again, that's why it's very important to note they ask for treatment of choice. Okay, treatment of choice. Next question. Which of the following are seen in patients with chronic arsenic poisoning? Okay, I want you to look through all of the options and you tell me what is not seen in acute arsenic poisoning. We discussed one of these features. One of these features we discussed. Immediately you should be, yes, very good, Stardust. Luminous vomit is seen where? It is seen in phosphorus. Okay, sorry, my handwriting is very poorly. I will erase that and write it correctly. Okay, seen in phosphorus poisoning.